covers variety of topics ranging from orbital foreign bodies, vascular malformations of orbit, and botulinum toxin. And we have the best of faculties today with us from the state and from the country. And special welcome to Dr. Usha Singh, who is the head of Oculoplasty Services, PGI Chandigarh. Welcome, ma'am. And also welcome to all the other faculties. With these words, I hand over the program to Dr. Marian, who has done a great job to organize this CME. Over to you, Dr. Marian.
Yeah, hi. Good evening all. I thank the KSOS Scientific Committee Chairman, Dr. Baston, as well as the Executive Committee for entrusting me this work of doing Oculoplasty webinar. My job is to introduce all the panelists as well as the moderators. First, let me introduce Dr. Ani Sridhar. She is a senior consultant and head of Department of Orbit Oculoplasty, Little Hospital, Angamaili. She is called as the mother of Kerala Oculoplastic Surgery. Okay. Welcome.
And my teacher also.
Yeah.
Okay.
I welcome Dr. Anne J.K. She is also a consultant at Little Flower Hospital, Angamaili. Welcome, Dr. Anne.
Thank you.
Moderators, Dr. Shebin Salim. She is a consultant at Giridhara Institute, Kochi. Dr. Anju, working at Commerce Hospital, Calicut. Dr. Saumya, working in Kozhikode, and Dr. Indu, again working in Comtrust, Talasheri. They all put their time and brain together to make this program. I especially thank Dr. Shebin, she's my colleague too, to organize the whole thing. So with these few words, I hand over to Dr. Shebin to start the sessions, please. Thank you.
Thank you, ma'am. Thank you so much. So I welcome Dr. Anju to introduce Usha, ma'am.
Yeah. Good evening. Good evening, everybody. It gives me great pleasure to invite as first speaker of the day. Dr. Usha Singh is a professor and head of the Department of Ophthalmology at Advanced Eye Center, PGI, and she's the current president of Oculoplastic Association of India. She has got numerous publications in peer-reviewed journals and many presentations in national and international conferences, as well as she's a member of, executive member of AIOS, NZOS, and OPI, and also a life member of International Society of Ocular Oncology. We are very glad to have you here today, ma'am. Today she will be talking to us on vascular malformations in a nutshell.
This might be, am I heard?
Yes,
Yeah,
madam.
Yes.
Yes.
Good evening, everybody. And thank you so much, Dr. Ani, Dr. Marian Pauli, and Dr. Shebin. May I just put my slides on?
Yes, ma'am.
How do I, just a second.
Share. Just
Yes. How do I go about?
please click on the share option, which is there in the below menu.
Share?
Yes,
Yes. Okay. I click on my slide. Is my slide visible?
Yes, it is visible, ma'am. We have.
Now you can go to slide.
Yes.
Okay. So, so once again, I would like to thank Marian Pauli. Thank you for inviting me to share my views on orbital vascular lesion. I'm so happy to be presenting in front of this learned gathering, and Kerala is a great place. So I wish to visit it sometime. So we will just talk about orbital vascular anomalies. So vascular anomalies is an umbrella term, basically. The orbital vascular anomalies, they constitute about 10 to 12%, and they vary greatly in their clinical behavior, and they may be nearly indistinguishable on clinical grounds alone. And they which leads to a lot of confusion in diagnosis and management. And they also have a diverse clinical spectrum, and the involvement ranges from pinpoint lesions to entire orbit and periorbita. So they present unique diagnostic and management challenges to an orbital, even to an experienced orbital surgeon. So as per uh, the ISWA classification 2018, which is based on radiological, histological, and natural history, and has been adopted by various specialties and some of the orbital surgeons. For accurate diagnosis and appropriate management, we need to have a deep understanding of the natural course, nomenclature, clinical features, and clinic imaging characteristics. So as per the Rootman's hemodynamic classification, or orbital vascular anomalies. Type 1 is a no-flow lesion. Type 2 is a low-flow lesion, which is venous-based. And type 3 is a high-flow lesion, which is arterial. Type 1 is, of course, it has no connection to the venous system. And among the high flow, we have AV malformations, and even now the cavernous hemangioma has come into this high flow lesion. And actually, it is a low flow AV malformation, but somehow it has been put in this group. From the orbital surgeon's point of view, is knowing the hemodynamics of the lesion, and this is what is most useful to determining the beginning, extent of treatment modality, adjunct procedures, embolization for safe and positive outcomes. So selection of treatment modality would depend upon the malformation, location, associated structures involved, and the extent of tissue involved. So if we look at this, the ocular adnexal vascular anomalies, this has been adopted from the ISWA classification. If you see in this classification, this arrow, the circle is slightly up. So there is one category called the malformation of major blood vessels. So this category is not seen, not reported in the orbit. So this is one discrepancy which is there. So at our Advanced Eye Center, we have analyzed 76 cases which were managed at the Advanced Eye Center. And as you can see from here, the eyelid swelling, proptosis, diminished vision, and increase of mass with posture, these are the main symptoms which are presenting and among our patients. So in our patients, superficial, the orbit is if it is involving preseptal areas, it is superficial. When it is retroseptal, it is deep and combined. It could be combined involving both the compartments, or it could be complex involving non-orbital structures. So this was the distribution among our cases, and majority of the cases, almost 35%, they were venous malformations. So coming to the management, so first is observation. Some of the lesions, they just need to be observed if they're not obstructing or causing any functional or vision loss. Sclerotherapy, embolization, surgical excision, or a combination. And among our cases, I've already said venous malformations were 34%. AVM also was quite a few. And LVM, lymphovenous malformations, they were 22%. We also saw some few rare ones also. So here is a patient. Here is a 4-year-old child who presented with acute onset painful proptosis. You can see the congenital chemosis, and the CT showed the mass lesion involving the intracorneal space and grossly proptosed globe, and it's pushing the globe out. So we just did a needle aspiration and reduced it, but however, with time, we had to. He looked much better. He improved, but however, he presented 2 years later. Now this is the only patient who had bilateral involvement. Even in the CT, you can see there's a little involvement of the other orbit also. So he came 2 years later with the swelling in the other eye orbit, and we just had to do a needle aspiration. But since it did not completely resolve, we did a complete excision. And at this time, we noticed that the patient, the cornea was smaller and had a cataract over here. So then he gave a history that he had undergone some neurosurgical intervention for the residual mass. And in the post-op period, he had lost his vision. We do not know where he has undergone that surgery. So these patients, they keep coming back repeatedly. Coming to the lymphatic malformation, the reasons for hyperplasia of lymphatics has long been unknown. Recent studies have identified activating mutation, that is PIK3CA, and that is phosphatidyl inositol 4,5 biphosphate 3 kinase catalytic subunit alpha gene in lymphovascular overgrowth disorders with 5 specific mutations which involve these 3 exons, 8, 10, and 21, and they account for majority of the cases. However, mutations have been found in 74% of 31 individuals with isolated lymphatic malformation. This is from the Seattle Children's Hospital group, and even in more than 90% from the cohort which was included in the study from Boston's Children's Hospital. But there is no correlation with the several subtypes, whether it is microcystic or macrocystic, there is no correlation. Several kinase inhibitors have the potential to block lymphatic endothelial cell proliferation. However, its effects have not been restricted to mutated cells, hence caution has to be exercised. The slow flow venous malformations. Here is a lady who presented, this is a 35-year-old lady who presented distensible lesion. So after bending, you can see how the lesion has become very marked. And this has grown rapidly for over 8 months, leading to complete ptosis. Then she had a recurrence 4 months after sclerotherapy. And we can see this MRI, which shows the T2 weighted images, and hyperintense septations we can see, and hypointense areas are suggestive of phleboliths within. And post-contrast, there are delayed heterogeneous enhancement. So all these signal characteristics, they are suggestive of a slow flow venous malformation. So we went ahead and excised this lesion. We used the glue for solidifying and minimizing the bleeding. And this was easily excised, and we could put a drain. And she looked fine in the post-operative period, and histopathology reported a cavernous hemangioma, and this is how she looks in the early and the late post-op. Here is another case, a case of a young girl who's a 14-year-old child, and she presented a bluish lesion for 4 years. Which is about 2 into 2.5 centimeter, which is non-pulsatile, no bruit, no trauma, but it increased on Valsalva. And the MRI showed that this lesion was pretty well circumscribed, and there were some flow voids within. And this is the dynamic MRI of this patient, and you can see with successive time planes, there is increase in the enhancement, there's intense enhancement takes place as we go further down the timeline. So which was suggesting a malformation. So at this time, we made a suggestion of a hemangioma. So at this time, we made a diagnosis of distensible vascular malformation involving the right orbit. So some of these conditions, they all distend: venous, veno-lymphatic malformation, lymphatic malformation, which was least unlikely. So as per the new proposed orbital vascular anomalies, we kept type 1 and type 2 malformation and possibility of any other lesion, which we had not thought of. So we went ahead and excised it with the glue-assisted excise mask, and you can see the histopathology report. It showed blood vessels and loose connective tissue, and the diagnosis capillary hemangioma. So the dynamic MRA and the histopathological diagnosis, they correlated as capillary hemangioma. So presentation of capillary hemangioma usually occurs after birth, but within the first 6 months of life, whereas 30% present at birth and 50% by 1 to 2 months and 90% by 6 months. Clinically, the capillary hemangiomas may present as a cutaneous, subcutaneous, or orbital lesion, and 80% are isolated. Acquired capillary hemangiomas, they appear to be true capillary hemangiomas, and they are very rare in the eyelid and periocular region. The etiology is unknown, probably associated with hormonal changes and increased estrogen levels during puberty and pregnancy. Our patient was a 14-year-old girl. So, but when we are seeing this kind of situation, we need to rule out some of these conditions like Kaposi sarcoma, angiosarcoma, acquired tufted angioma and intravascular papillary endothelial hyperplasia. Now, here is another case. This is a 25-year-old lady, and she complained of tense swelling in the right upper lid and the brow region for 4 months, and it was associated with pain. So she gave a history of trauma to forehead 4 months ago, and this trauma is pretty significant because she banged her head against the door with a lot of force. And so this was, though vision was maintained, she had a tense, tender, fluctuant swelling with well-defined borders. And we were thinking in terms of hemorrhage, subperiosteal probably, because it was very tense, and or hemorrhage into some pre-existing vascular lesion. Dynamic MRA showed a hypointense lesion of the superior orbit, as we can see over here, and in T2, a heterogeneous enhancement, few septations and hyperintense lesion. So dynamic MRA, there was superior ophthalmic vein was draining the lesion. There was no lymphovenous malformation. So we went ahead and excised it, and the excision histopath, we'll come to that. So it turned out to be a Masson's hemangioma. So this was diagnosed on histopathology. It's an absence of extravascular extension. It has more than 2 to 3 layers of endothelial covering papillary projections, absence of mitosis. Reactive vascular proliferation following traumatic vascular stasis due to the release of basic fibroblast growth factor by the invading macrophages to the trauma site with proliferation of endothelial cells. So this was a mesenchymal hemangioma. And this was first described in 1923 by Pierre Masson in a 60-year-old patient. It is rare in the orbit and periorbita. Case series of lesions occurring in the eyelid, they are very rare, and some isolated cases reported, and vision loss has been reported in 1 case. They are small firm masses with recurrent bleeding. Treatment is excision, beta-adrenergic antagonist, adjuvant radiotherapy and chemotherapy, and laser ablation. So these have been used, and this is the report, a case of the first case which was reported. So here is another patient. Here came with proptosis for about 1 year, but the findings were very typical. The CT was showing multiple calcific foci, which are suggestive of phlebolytics, and angiography showed, we can see the angiogram, which does not show any arterial supply to this lesion. So we went ahead and excised it. You can see it is infiltrating beyond the Wittners ligament into the orbit, and this is infiltrating superior to the Wittners ligament. So we went ahead and gradually removed all this with the help of glue. Luckily, we were able to save the LPS muscle, and she did well. And histopathology reported an orbital varix. Now here is another patient, a 20-year-old female. She complained of distensible eyelid swelling and reddish mass in the upper left superior temporal conjunctiva for 3 years. And it was distensible, so we were thinking in terms of varix. And on T2 weighted MRI image, we see a hyperintense lesion in the lateral and superior extracorneal space, pretty well defined. Intraop glue as surgical near total excision was done, and we use this glue, that N-butyl cyanoacrylate, in 1 cc tuberculin syringe. We injected into the lesion and excised it. Histopathology reported an orbital AVM, a very different looking orbital AVM from what we have seen earlier. Now, this is another patient, a 20-year-old female, and she complained of upper eyelid swelling, headache, tinnitus of 4 years duration. Vision was 20/40, and she had a proptosis of 8 millimeter. So there was a lateral gaze restriction. There was a bluish mass in the supero-nasal quadrant, which was very anteriorly placed, preceptal, almost preceptal. So it was very firm and hard to feel. Rest of the orbit and everything was very boggy to feel. It was soft, and it was pulsatile. And you can see all the corkscrew vessels in the conjunctiva over here. And so this was suggestive of AV malformation. And so her record showed that she was a known case of AVM of the orbit, and she had undergone embolization of the lesion 4 years ago. So she was presenting with a recurrence of symptoms to us at 1.5 years duration of. So AVMs are best managed by combined approach of preoperative selective angiography with embolization followed by resection of the nidus, or stereotactic radiosurgery can be used. So this is the MRI when she had first presented to the neurology department, the intervention neuroradiologist, and you can see that the muscles are thickened, the prominent artery is dilated, the ophthalmic artery is dilated, and you can see there's a superior ophthalmic vein is dilated, and you can see here is a dilated superior ophthalmic vein, and the location of this lesion, the active portion is very anterior in the superior nasal quadrant, and we can see this dilated artery with feeder branches. So she had undergone a selective angiography and embolization with onyx. So this lesion had been occluded, embolized completely, and she was fine for about 3 years. So, and you can see this is a translucent, this is the onyx which is visible on this image. So when she presented to us, she was having this, what you say, the tantalum powder and which had been used to embolize. So this had solidified, and this was what we were palpating. And so this was a case of recanalization of embolized AVM. And so we went ahead and excised it very carefully. It was a very challenging situation because she was also a thalassaemic patient, and we were doing it under microscope, going about just less than a millimeter per in any direction, and we were very careful with all the instrument, and it kept on pulsating. Finally, somehow we could separate the tissues underneath, and you can see this gray blue mass lesion, which was the glue cast, and this is the vessel next to it. So we could pass the suture underneath, ligated it on 2 ends, and excise it. So the ISWA classification 2018, there is something which does not fit into the orbital surgeon's viewpoint, and it has been widely adopted by other specialties, but among the orbital surgeons, they do not strictly adhere to it because of the peculiarities of the orbital vascular anomalies. So first of all, it is a challenging phenotype. Then there is a lot of diversity and overlapping clinical pictures, and inconsistent naming and the use of unstable classifications, they undermine the understanding of OVA, orbital vascular anomalies. So they are difficult to comprehend and understand. So in 2022, Tawfiq and Dutton, they have simplified the revised version of ISWA 2018, and they concluded that adopting updated terminology and a unified classifications concept system that fits both research and diagnosis. And they have omitted all the obsolete terms. The reason being, using obsolete but contextually wrong terminology may deprive patients of appropriate care. The minor restructuring of the ISWA 2018 classification by Tawfiq and Dutton has clinical and therapeutic applicability. This is the publication, and it has come out in 2022. Modified classification of orbital and periorbital vascular anomalies, and they left out these 2 categories: anomalies of major named vessel, which is not seen in the, not applicable in the orbit, and the second one they omitted was provisionally unclassified vascular anomalies. None of these lesions have been reported in the orbital literature so far. So coming to the conclusions, since majority of these vascular malformations in the orbit are rare and they have multifaceted presentation, they are difficult to diagnose and require multidisciplinary approach in managing, is undoubtedly the reason for lack of original studies being reported by orbital surgeons. Moreover, there is a non-availability of instructions for an orbital surgeon on appropriate case selection and stratagems on surgical pointers for getting optimal results and avoidance of complications. However, in the recent years, the understanding of these orbital anomalies has undergone a substantial improvement over the past decade, with improving analysis of the clinical, histopathological, and imaging characteristics. Orbital surgeons have forged ahead to take up these cases to offer relief, as selective cases can be best managed by the orbital surgeon with a preoperative workup in collaboration with colleagues from other specialties. Moreover, the management of orbital vascular lesions has upgraded with the development of variety of treatment advances which make the interventions minimal and surgery safer with fewer complications. Thank you very much.
Thank you, Dr. Usha, for such an excellent talk. That it was beautifully explained with all the cases, and it is indeed a very difficult case scenario to manage. Thank you for that. Expert panelist, Annie, madam, would you like to add anything, or Anne, madam?
Can
Yes,
I talk? Can I exit it?
Yes, madam. Okay.
yeah, you have.
Yeah.
So,
Okay.
what investigations actually do you do when such a case, a suspected case of vascular malformation comes to you?
So investigations is specific investigations being depending on the type of lesion you're expecting. If it is distensible, we would like to have a dynamic MRA or a venography, depending on what we find. And of course, every patient will undergo DSA or MRI. Initially MRI, then DSA. Some of these patients, they already carry reports. So we just go ahead, and if it's their diagnosis still not clear, we just go ahead and get a further investigations. And of course, a workup for all the surgery, which we have to do. That is there. So, and sometimes the workup requires quite a lot of time, and these patients have to be prepared, and they have to be spoken again and again about the risks involved. Some of these AVMs are very risky, and we can always land up in some problem, if not prepared for it. So a preoperative workup, we must spend as much time as possible in getting all the investigations done, whether it's a CT or a DSA or a dynamic MRA. Sometimes dynamic MRA helps. There's a study by Alon Kahana. He has done dynamic MRA, and it could differentiate certain lesions one from the other, like in some of our cases.
By looking at the filling of the lesions, isn't it?
Yeah, it slowly fills up, or it's like I showed one case, there was a gradual, as the time passed, there was a gradual increase in the enhancement.
Yeah.
So we are not talking about tumors over here.
Yeah. DSA is digital subtraction angiography, isn't it?
Yeah.
Yeah. Okay. So in a suspected case of lymphangioma, so if it is producing proptosis, or if it has already produced a bleed, so what will be your management? Do you give bleomycin anytime? Yeah.
See, nowadays the terminology lymphangioma is being changed to lymphatic malformations. They are no more called lymphangiomas, and yes, we have to see what is the extent of involvement. So if it has bled, of course, you have to decompress the orbit. Okay, like we had done in the first case, as I've shown. But for all vascular lesions, the time to intervene is if they are producing vascular, vision dysfunction, or they're causing restriction of more motility, or they're grossly grotesque, and patient is seeking a treatment for it. And so in those are the conditions where we intervene. Otherwise, most of the cases, they are just managed conservatively and intervene only when vision or function is hampered.
Okay.
Or it's causing amblyopia in children or something like that, ptosis. Those are the conditions.
So monitor vision
between.
Pardon?
Madam, this was an excellent collection of cases. I just wanted to know, how do you choose what sclerosant you have to inject? In some cases, most of the cases you have used cyanoacrylate blue, right? No?
That is before surgical excision. I remember Ania had asked me whether I use bleomycin. Yes, we use bleomycin, So it is useful, and in most of the cases, it will reduce the size of the lesion if it is, if it is cystic kind. And we will not use bleomycin into the deep orbit, deeper lesions, because that can lead to problems like compartment syndrome. So if they're anteriorly located and it can be managed easily, then we inject bleomycin. But bleomycin, that's it. I mean, but these cases do recur. How much of a good response we get, with due course of time, I've seen that they will come back with some recurrence or the other. But we have to keep injecting. If it is not very severe, then you keep injecting bleomycin, but not in the deeper lesions. We don't do for that. But then if the, let's say, lesion are over the huge period of, let's say, 10, 12 years, it has bled and rebled and it has advanced and occupying most of the orbit. Those cases, bleomycin is not going to work in any way. So because everything is fibrosed and they're enveloping the structures around the nerve or around the optic nerve. So we have to go ahead and excise it cautiously. If you want the child to have some future, some kind of better future, then you have to take the thing and
It will be very difficult, no? So quite a difficult surgery.
Yeah, it is a difficult surgery, but yeah, we have done. But bleomycin just tiding over a period.
Yeah.
Really rebleeds or sometime later or something. It's just that. Ultimately, it's a surgical excision which has, there's a lot of fibrosis in that.
Do you
Thank you,
use
doctor.
image guidance always before injecting?
Pardon?
Image guided, the injection will be image guided, or how will you go about that?
I'm not getting the question. Can somebody
Would you inject it using an image tube, like
before injecting bleomycin, what?
Is
would
it
you
image
use,
guided?
Will it be image guided? I am asking.
No, we don't use image guided. I do it directly. But if it is in the orbit and we are tackling the orbit lesion, then yes, under ultrasound guidance. But if it is anteriorly located, I don't do that. We just stop the backflow of the lesion and then.
Yeah. Okay. A very good illustration of cases, Dr. Usha.
Thank you.
Yeah.
Thank you so much, Dr. Usha. In the interest of time, I would like to call upon Dr. Shebin to introduce the next speaker.
Thank you so
Anshu.
much. And
Yeah.
with your permission, I'd like to leave. Thank you.
Thank you so much,
Thank
madam.
you so much.
Thank you so much.
Thank
Bye.
you.
Hello, hope I am audible.
Yes, madam.
So our next speaker is Dr. Reena ma'am, who will be talking on orbital infections, a case-based discussion. Madam is currently the professor of ophthalmology at Thrissur Medical College. She is what we can call a mentor of mentors. Over her career of more than 25 years, she has trained umpteen number of students. She is specialized in ocular immunology and has presented in many national and international forums.
Thank you, thank you. Let me see it. Oh,
No, I think Angit has already shared your slide.
is it? Okay, thank you so much.
Okay.
So
Angit,
I have
can
to go to the first slide, please. Before I start, I must thank Marian and team KSOS for giving me this opportunity. Okay, in this, we'll straight away start the cases. In this presentation, I have included a few orbital and periorbital infections, which are, the presentation is atypical. So I believe that all of you are familiar with the conventional orbital cellulitis like classic features. Next slide. So this is our first case. So, this is mainly for the postgraduates. So I will be talking on their level only. So if you are coming across a patient with a persistent orbital infection, that means whatever is there, it is not getting controlled with whatever adequate treatment, whatever you feel as adequate treatment is given. but still there is some kind of a persistent infection. Next slide. So this is a 5-year-old girl. She had a trauma, a fall or an injury with a stick or something like that. A primary repair was done by the primary ophthalmologist, and the wound healed, but it was bursting with a discharge in between. And she had attended 2 or 3 tertiary centers in between. She had 2 interventions in between. And this was the 4th time she was presenting to us. And this is how she showed. You could see 2 collections, subcutaneous collections of pus pointing swellings, one on the upper lid and one on the forehead. And the smaller swelling on the forehead was bursting and discharging pus in between. That was the complaint. And the child also had some kind of a ptosis. Next. So she carried many imagings with her when she presented to us, but it was not contributing to any or any helping in the diagnosis. So in such a scenario, a child who had a trauma presenting 3 months later with kind of a persistent infection, what is the first thing that should come to your mind? Next slide. So the first thing you should think about is the possibility of a retained foreign body. The primary repair was done elsewhere and then they are presenting. That means something might have been missed in the first evaluation. So in the future imagings, it was not shown. So if it is a radiopaque foreign body, that means if it is a metallic or something which can be picked up by the CT scan, then it is easy to diagnose. But when it is an organic foreign body, as in this particular history, where it is a wooden particle or a branch of a tree that is causing this thing, this injury, you can miss this organic foreign body unless you carefully search for it. Because the foreign body, when it is organic, it usually mimics air or fat, which is very commonly seen within the orbital tissues and can be merged with the fat, orbital fat. So you can easily miss such a foreign body. So the point is that unless you have a high index of suspicion, it is very easy for you to miss a foreign body in cases of orbital infections. So whenever there is a persistent discharge or persistent infection, then you should always think about the possibility of a retained foreign body. So here also, next slide. Here also we suspected it and we took an imaging, but here in the coronal section we are not getting any clue. And next slide. Next slide. And even the previous one. And even in the even the radiologist was not committing any foreign body. It may be there, may not be there, kind of reports only you will get. But when you clinically correlate, that is why your index of suspicion is very important. If you clinically correlate, maybe there is something which is connecting with the clinical picture. There you can suspect. That is the only thing you can do. And there is a reason, and that is why we are justified in exploring the case. So we went ahead and did a surgical exploration. Next one. So here you could see that there is a foreign body, which is a wooden piece that is removed from this injury. The surgery was relatively difficult because of the previous surgery, scarring. The injured tract has completely destroyed or deviated from the. So it was very difficult to get it in and remove it entirely. But the possibility of all sequelae that you expect, that like kind of injury to the levator, ptosis, possibility of ptosis, all those things has to be explained prior to that. And but the child recovered fully. Next slide. So luckily, the child recovered fully and the foreign body is removed and there was no other complications of procedure. Next slide. So the point here is that whenever there is persistent infection, you should think about the possibility of a retained foreign body, and organic foreign bodies are easily missed in the imaging unless you carefully search for it and look for it. So the second case is also something similar, but it is a little more serious one. When most of the time, whenever you are posted in an emergency duty, you may be seeing a lot of lead injuries and you will do the lead repair and send the patient. And many times it can be a little messy because of the trauma, or there can be dirty wounds and all those things. And eyeball swelling, there will be periorbital swelling. So unless you examine the eye properly, you can miss certain things. So next slide. So this is a patient, a 63-year-old lady. She had history of fall over a coconut leaf 3 or 4 weeks before, and she's primary ophthalmologist repaired the wound, and initial repair is done, and the eye was swollen, and we should believe that nobody had examined the eye at that time properly, because when the edema subsided, the patient realized that she's not seeing with that eye, and that is what prompted her to go back to the doctor again. And then they did a CT scan and found out some fracture or something, and then they referred the patients. Next slide. So that is about the history. At the time of presentation, patient had a dilated fixed pupil, no perception of light vision, and total ophthalmoplegia. Next slide. So you can see that the wound is kind of healing, but there is dirty discharge that is still pouring in. And this is picture is taken after cleaning. And there was absolutely no movement, total ophthalmoplegia, and no perception of light. Next slide. So we naturally suspected the possibility of a retained foreign body, and an imaging was repeated. You could see a kind of blackish shadow which is extending up to the orbital apex along the lateral rectus muscle in this proptused eye. Next slide. So we did an exploration under GA, and this is you can see the size of the foreign body and the length of the foreign body. It is more than the size length of the orbit. The smaller piece, which is triangular head was actually deeply impacted in the orbital apex, and pulling it was really challenging, and risky, because it might have been impacting on a blood vessel or a cavernous sinus. We don't know, because it was too tightly impacted in the orbital apex. And this also explains the ophthalmoplegia that the patient had. And any debris that was there has to be removed. Otherwise, the symptoms are not going to get resolved completely. So this is one. Next slide. Next slide. So the patient recovered very slowly. Eye motility to a certain extent improved, but vision remained now pale. So the eye vision was lost, but other symptoms all resolved. And the point, take-home message from this case is that if you are repairing an eyelid tear, and the patient is having some orbital signs or eyeball involvement, most of the time eyeball involvement like subconjunctival hemorrhage or a corneal foreign body or hyphema, all those things are usually easily picked up. But then when there are orbital signs like periorbital swelling, motility disturbances, and all these things are easily missed unless you retract the eyelids and examine properly. So if you see a lid tear, you have to do complete debridement, and you have to examine to rule out the possibility of a coexisting orbital or a globe eyeball injury along with it. And if it is an orbital injury, motility is the most important thing. If the movements are restricted, you should always suspect something is wrong with the orbit also. Fullness and proptosis can be there due to external or anterior involvement also. But then if it is a deep orbital proptosis and motility restriction, then there is much more serious orbital injury. So that should not be missed in any cases, any case of lid trauma. That is the message from this case. Next one. This I already said. So these retained orbital foreign bodies can present at any time. We had cases which are presented years later also with the sino-orbital extensive fungal infections, exophthalmos, fistula, sinus, all neurological complications. So unless you suspect the possibility of a retained foreign body, which is organic in nature, this can be easily missed, and patient can have severe morbidities later on. And like in this case, many cases can even lose vision completely. So that is a point which you have to keep in your mind in those who are taking emergency duties. They have to do the debridement properly and before closing the wound. Next one. So this is whenever we think about orbital infection, most of the time we believe that there are a lot of signs like proptosis, pain, restricted motility, visual disturbances and all. But this boy, next one. This boy, he came just because he's having some discomfort in the eye for a refraction or a checkup. And what we saw was that the eyeball is shifted up, some kind of a proptosis is there, and there is some fullness in the right cheek. He was very hesitant to, for evaluation and measurements and all, but the proptosis was confirmed clinically. So that is why the moments where normal vision was normal, everything else was normal, and he's a student in a mechanical student in an ITI. And he was very hesitant to undergo investigations, but we insisted for an imaging. Next slide. And all the other investigations were normal, lab investigations and all, but in the imaging, next one, we could see an extensive involvement of the sinuses and the medial orbit with nasopharyngeal lesions extensively involving into the medial orbit. And this is heterogeneous and a lobulated kind of, and you can see that it is mostly of an ENT case. So we refer the case to the ENT people. Next slide. So they did a functional endoscopic sinus surgery, and debridement was done, and the specimen was sent. Next one. The specimen was sent both for pathological and histopathological and microbiological evaluation, and we could diagnose blastomycosis, which is a very rare entity in the orbit, but it can occur in the sinuses. Next one. So after the complete debridement, he needed oral antifungal treatment for a longer duration, 6 to 12 months, and he didn't come back for follow-up. So I don't know what happened afterwards. Next one. So this is one example where the proptosis can be due to an infection, but it can be silent and it can be very extensive even without much clinical inflammatory signs or signs of infection and externally. So that also is a possibility. These are all rare ones, but still it is all possibility. You should keep in mind, instead of getting deviated, if you just leave those cases, they can become very extensive and can involve the orbital apex, and that can cause visual disturbances also. Because in these cases, visual disturbances was not there, the patient came present very late. So now coming to the fourth case, next one, whether an infection can present as an orbital inflammatory disease. We know that orbital inflammatory disease has got a different set of symptoms usually, but sometimes it can be confusion with the orbital infection. Whether it is inflammation or infection is, especially in unilateral cases where there is no specific history, no sinusitis, then maybe sometimes it can be a little confusing. This boy actually had severe signs of inflammation, which was initially diagnosed by elsewhere as a preseptal or an orbital cellulitis, because he was treated with intravenous antibiotics and his recovery was partial, and so they referred the case. And when he was referred, we could see some kind of a fullness, a mild proptosis, and some kind of a fullness which is mostly confined to the superior orbit. And we advised an imaging. Next one. So we did an ultrasound, and this is the imaging the patient carried. Ultrasound we repeated because the swelling was very soft in consistency, and we could see some kind of a swelling in the ultrasound. And so we continued the antibiotics and corticosteroids, but after the corticosteroids, some symptoms and signs improved. Next one. But there was a definite mass by then. So we did repeated with an MRI, and this is what we could see. We could see a cystic swelling in the supralateral orbit. Next one. So next one. So we went ahead and did a surgery, but what we could see that the cyst was not separable in certain parts because it was adherent. Already it has had ruptured or might have caused some inflammation. So it was not separable from some areas. So I just aspirated the fluid so that it will shrink, and then we can remove it. And then I realized that it is a double wall cyst, and it suddenly clicked to me that maybe it is a hydatid cyst. So the spillage and the next one. So that was confirmed histopathologically as a hydatid cyst of the orbit. Next one. It's a very rare one in the orbit. Next one. So usually because of the spillage and all, we had to give systemic albendazole therapy for a long duration. He was also evaluated. Next one. He was also evaluated for a next one. Evaluated for systemic involvement. in the form of neurocystic cirrhosis or a GIT involvement by doing ultrasound and further LFT and all those things. And infectious disease consultation was also done. They advised him treatment for a long duration, 3 months or 3 weeks. I'm not very sure right now. Next slide. And he was also given systemic steroids because of the spillage which that happened on the table. He was kept under follow-up and he was cured of that. After that, he had no symptoms. Next one. So that is one example where an orbital inflammatory disease, which you as the primary diagnosis, can also be caused by a kind of parasitic infection. So any dermoid cyst or any parasitic cyst can have rupture and manifest with the orbital inflammatory signs initially. Later on, histopathology alone will give you the correct, accurate diagnosis. So shall I stop or shall I continue, Marian? One more. I can't hear you.
Yes, ma'am. One more your case you're presenting,
Yeah,
ma'am,
yeah.
right?
Yeah. Shall I continue?
Yes, madam.
Shall
Yes, ma'am. Yes.
Okay. So orbital infections, we almost always believe it as an unilateral disease. Can it occur as a bilateral disease is the next case. Next one. So this is a 4-year-old boy who from North Kerala. He actually presented to us like this. And with the bilateral proptosis, child was very irritable, toxic, and very uncooperative for the examination. But the history they gave was that 3 weeks before he had a infection of sinusitis, upper respiratory infection and sinusitis, for which he had treatment from a secondary level hospital with intravenous antibiotics, and the symptoms got improved. And whatever this proptosis which we are seeing is progressive, and it has been there for the last 4 days, bilateral, symmetrical, and progressive proptosis in both eyes. For about 4 days duration. So the pediatric people have done all the investigations, including bone marrow, and everything was negative. Child was very toxic, irritable, and febrile. Next one. So this is the imaging they carried, and that is the 3 weeks ago, mild sinusitis was there, and before which he had treatment. Next one. So we repeated with an MRI, and this is what we could see. You could see supromedially in both the orbits, multiloculated cystic areas with fluid-filled cavities, which is extending out to the orbital apex, and it is bilateral. Next one. So we were not sure about the diagnosis at that. We had discussions with the radiologist, and they said it is pus. You have to suspect orbital abscess, etc. And the other DD I could find out was highlighted again, but then by the time the child got anesthesia fitness, because he was very toxic and very sick, and the GA fitness and everything, it took 48 hours or 24 to 36 hours later, this was the presentation on the table. You can see that there is no diagnostic dilemma. Then both the eyes are so proptosed, cornea, totally the eyeball is outside. You can see that the pus is pointing in both eyes, and you through transconjunctivally we entered, and supromedial orbitotomy was done, and the pus was just pouring in. Next one. So we aspirated almost 10 cc of pus. Actually, it was as thick pus, so I had to wash with I have to use the suction apparatus to aspirate the pus, and then the whole cavity was so huge then, and it was washed with antibiotic solution, and each eye was done separately. With the ideal all precautions to protect the cornea, because cornea was so much like in a crater surrounded by the proptosed chemosed conjunctiva and all. So cornea has to be already, it was exposed, dry and lustreless, but then we protected the cornea from the pus flowing in. Pus was very thick actually. And then microbiology reported it as Acinetobacter, which is very sensitive, very resistant, sensitive only to piperacillin. Next one. The recovery was dramatic. Next day itself, the eyes were covered, and child improved drastically. Within a period of 1 week's time, he was almost normal and completely recovered with no corneal scarring or anything. Next one. So this is one situation. This was a poster, that is why. So this was one situation where the disease was bilateral, and it was life-threatening. And we could save the child by the intervention, which will help not only to recover the vision, but also the life of the child. So this is one lesson that a suboptimal treatment to upper respiratory infections, sinus infections, or orbital cellulitis itself can lead to abscess formation, and in children especially, it can cross over to the next side through the foramina, or maybe through the lamina papyracea, or even infective dehiscences in the bone. There are so many routes, or through emissary veins, it can reach the other side. So bilaterality is not something common, but it can also occur, and you should keep that diagnosis also in mind whenever this kind of a present. There are some reports, not many reports, but few reports are already there. So this is a success story, but may not be always. A child can succumb to this because a child was very, very high risk and dangerously ill at the time of, and very high risk anesthesia also. And next one. So this is the route. I think the prolonged antibiotic therapy and suboptimal treatment is one of the reasons why these abscesses are formed. The point to remember here is that these abscesses, if it is located posteriorly, here it is a multiloculated and very huge one, but in certain other situations where the abscess forms, it will be, if it is situated in the posterior orbit, the vision will be threatened much early in the stage of the disease, but anterior signs will be much less. So if you see a kind of proptosis, but there is not much of an infective or inflammatory signs, but the child is having upper respiratory or sinus infection, and then you should always suspect an orbital abscess, which may be located a little deeper. There the situation is much more at risk to the vision, but the signs will be much less. So you should always remember that orbital abscess is one condition which is worse compared to this orbital cellulitis, because orbital cellulitis, because of the proptosis, chemosis, redness and all, patients will at least report early. But when it is partially treated and an abscess is formed, it will be much more subacute and chronic, and the presentation will be delayed. And if it is posterior, it can rupture and produce CNS complications and even risk to life in children, especially in children. So this is something which always you should keep in your mind, and an MRI is a must in these cases to diagnose, and timely intervention is very, very important. I have 2 slides, so continue. Next one. Next one. Next one. So there are, that is about orbital disease. 2 cases of periorbital, that is dacrocystitis, we know that. Next one, watering as a symptom. We know that dacrocystitis is also one of the reasons for orbital infection when it is a source of infection, or a focus of infection. In this lady, she was on treatment for dacrocystitis for a long time from many centers, and she was not improving, watering. And finally, when I saw her, I could see a swelling. The swelling was not on the sac area. Ideally, it should be a little down, but in this particular lady, you could see it is basically the canalicular area or the canthus that is swollen. So, and when we word, you can see that the punctum is totally occluded. So we took her to the theater, and I tried to dilate the punctum. Next one. So this is what a dacrylithiasis is. So it's a chronic canaliculitis. When it gets blocked, you can get this kind of concretions and a kind of cheesy material filling the canaliculus, and the stone kind of things were coming out, and it was continuously coming out. I had to sit and do for 30 minutes or so to remove it entirely. What is it caused? This is also caused by an organism called actinomyces. Next slide. So this chronic canaliculitis complication is dacrylithiasis. It's also a rare condition, but it can also be there, presenting as watering, and one has to think about this condition instead of treating it as orbital dacrocystitis. So this usually responds to crystalline penicillin eye drops very well. Next one. This is rhinosporidiosis, because this most people are familiar with. Here, the history of bleeding or nasal bleeding or chronic nasal obstruction, along with the swelling, most of the time it is rhinosporidiosis, which is again an infective condition in the periorbital region. So I just included that. That's all. Thank you. Next slide. Thank you.
Thank you, ma'am. Thank you so much for sharing this fascinating array of cases with so many take-home points. For the interest of time, I think we should move on to the next discussion.
Thank you.
Thank you so much, ma'am. I welcome Dr. Soumya for introducing the next speaker.
Good evening, everyone. Thank you, Dr. Marian, Dr. Shebin, and KSOS for this opportunity. Next, we have Dr. Ridhija Thomas Grover. She is a consultant oculoplastic surgeon at Vision Eye Center, New Delhi. She has done her fellowship in oculoplasty from Narayana Netralaya, Bangalore, and she will be talking today about botulinum toxin injections for beginners. Over to you, Dr. Ridhija.
Good evening, everyone. I hope you can hear me.
Very well. Yes.
Thank you, Dr. Marian ma'am, for having me in this session, and of course, the great team that she has organizing it. So I'll just be talking about botulinum toxin, just an overview for beginner injectors. It's mainly used in our setting for blepharospasm, hemifacial spasm, and strabismologists also use it. And of course, for cosmetic issues. And what is botulinum toxin? It's basically a neurotoxin which sort of acts at the neuromuscular junction to prevent the release of acetylcholine. And what it does is it inhibits the release of acetylcholine from the presynaptic motor neurons. And the lethal dose, we only have to worry about it when it's injected in larger muscle groups. But as ophthalmologists, we only inject it in the face. So the maximum we would inject is about 60 to 80 units. So it's nothing to worry about. Now, the ones that we have available commercially are the Allergan Botox, the Xeomin by Merz, Dysport, and the one which is made in India, that is the Stanox. The different doses that are available, you get 50 unit vials, 100 unit vials, and 200 unit vials, and I'll tell you how to dilute them. So before you do the procedure for the patient, it's ideal to take photos and videos with animation prior to the procedure and application of a eutectic mixture like Prilox, which is prilocaine and lidocaine, over the face to numb the areas or prepare them with ice packs. When you reconstitute, these are the various volumes that you can use in order to have different dilutions. The most common one that we do is injecting 2 ml of preservative-free saline to get 2.5 units per 0.1 ml. And when you're inserting the needle into the rubber stopper of the botulinum toxin vial, you sort of let go of the plunger. So if the vacuum sucks the saline into it, it means it's a viable vial. In case it doesn't, it probably is not a viable one. After you mix the vial, you should store it in a refrigerator that is between 2 to 8 degrees Celsius, and you can use it between 1 to 6 weeks. The Xeomin one, there are studies that it can be used even up to 52 weeks, although we usually don't use it beyond 2 months. So the cold chain is very important that it's maintained, and it's important that we don't freeze it so that cracks don't develop in the vial. And it's important that your staff also is aware of this cold chain so that in the OPD, when you're reusing, the cold chain is maintained. The syringe that we use to mix would be the 26 gauge needle, and small diameter needles should be avoided so that it doesn't vigorously splash in the vial. And small diameter ones are used at the time of injection with a 1 ml syringe. Some people prefer to use insulin syringes. However, with an insulin syringe, you can't remove the needle, so it can get blunt at the tip. Could be useful for just an epiphora injection, but a blunt tip would be painful for the skin. This is basically what you need. You need your vial of botulinum toxin, no financial interest, your saline injection, a 2 ml syringe to mix it, if that's the dilution you're using, or if you need more, you can use more. A lignocaine prilocaine cream, that is Prilox, and the 1 ml syringe with a 30 gauge needle. So the indications which are therapeutic are, of course, for the benign essential blepharospasm, most commonly hemifacial spasm, rarely for orbicularis myokymia, which lasts beyond a month or two, and of course for functional epiphora. And the cosmetic indications are for the dynamic facial wrinkles, the static wrinkles, the Botox brow lift or the chemical brow lift, and for upper eyelid retraction secondary to thyroid eye disease. So the dosage, this is an approximate dosage, but everybody needs to sort of look at how severe the condition is and decide the dosage based on prior experience. And also let the patient know that after the initial dose, you would be titrating the dose based on the effect that they have. And the effect should last between 3 to 5 months. Some of the contraindications to giving the injection are, of course, neuropathic diseases, neuromuscular junction disorders such as myasthenia gravis, and pregnancy, and a previous hypersensitivity reaction, although this is more rare now. And a relative contraindication would be bleeding disorders, or if a patient is on antiplatelets, but they can stop the drug 3 to 5 days prior to the injection if you are worried about having a bruise form. So these are the muscles into which we inject mainly. And here you can see the frontalis, the procerus, the corrugator, the depressor supercilii, the orbicularis oculi, and these are the levator of the lips as well as the zygomaticus, which leads to the smile. So this would be an area which we would avoid to avoid a drooping of the angle of the mouth. And these are all the lines associated with these muscles into which we inject. The most common is, of course, for us, the frown lines, the horizontal forehead lines, and the crow's feet. And for the eyebrow lift, you would inject laterally closer to the orbicularis oculi so that the depressors are counteracted. And these are the lines which you see, that is the lines of expression and the lines which develop with aging. So each of these areas need to be injected carefully in order to avoid any side effects, which I will be coming to later. Now, when you inject the procerus or the corrugator, you hold the muscle in between your hand and you inject directly into the muscle. And later on, when you're going over to the eyelid, you need to inject laterally and lower down to avoid the levator getting injected. Now, this is some of the effects that you get by injecting into the forehead muscles for the vertical lines. And this is a patient with blepharospasm and with lower face involvement. He's actually got Meeks syndrome, but he has a lot of relief after the botulinum toxin injection. This is another patient with right-sided hemifacial spasm who also, you can see, has relief after the injection. Usually the injection starts to kick in about 48 to 72 hours after the injection, and the peak effect comes at around 10 days and lasts about 3 to 5 months. Now, in eyelid retraction, you need to evert the eyelid and give the injection where the mular muscle would be just subconjunctivally here. You can start with 2.5 units and go up to 7.5 units based on how severe the retraction is. It's also used in scar modulation in order to relax the muscles around, and also for the fibroblast activity that it has. So you can consider it along with your 5-fluorouracil or your triamcinolone. There's something called mesobotox, which is basically for the skin glow. So multiple injections, micro dosage injections are given very superficially in order to improve the skin texture. Other uses cosmetically, which we could potentially do, is for this gummy smile. So that is to bring down the lip, and also for facial asymmetry, and for the neck. Now it's most popularly used to reduce the bulkiness of the trapezius. When it comes to the lacrimal gland injection, you can see here we're using an insulin syringe. We retract the upper lid, find the lacrimal gland, tell the patient to look down and inwards, and inject directly into the palpebral lobe of the lacrimal gland. After this, it's important to tell the patient to use lubricants. The areas to avoid are very close to the brow because it can cause brow ptosis. Right in the center of the lid or towards the septum, that could lead to ptosis, it could lead to diplopia. And of course, this region which contains the levator anguli, oris, and the elevators of the mouth, it can cause depression and drooling. The other side effects are, of course, lag of thalamus when the eye doesn't close completely. This is a photo that a patient sent after she developed some amount of ptosis. It's important to just reassure them and tell them that it would resolve within 4 to 5 weeks on its own. You could ask them to do some cold compresses. And you can develop eyelid hematomas. So it's important to discourage patients from scheduling a Botox injection or a botulinum toxin injection within 2 weeks of important events, so that they don't have bruising just before a party or something. And avoid areas where there are visible vessels or telangiectasias. A post-procedure ice pack would also help in some vasoconstriction. And you should counsel patients who are predisposed to this bruising. Now, another effect or a side effect is that the botulinum toxin could be ineffective. So if it's improperly reconstituted or improperly mixed, that is mixed vigorously, or improperly stored, that is not refrigerated, it could cause a less than full strength effect. Now, after the procedure, it's important to tell the patient not to lie down, although this is not really something that we strictly follow. But more important than that is that they don't rub the treated area for at least 4 hours. Avoid any cosmetic treatments such as chemical peels, etc. after the injection for about 2 weeks. Avoid makeup immediately after. From the next day, they can use the makeup. And to report if there is any increased pain, swelling, redness, any blisters which would suggest any abscess formation, they should come and report to you immediately. And usually patients follow up every 3 to 5 months, but the patient's subjective benefit would also be a factor to determine when they return. So some people, if they're very anxious or if they're very worried by the issue, or if they have a severe form like apraxia of eyelid opening, then they would probably come back much sooner. But people who have more minor symptoms or for whom it's working longer, who are also doing some meditation or some kind of breathing exercises to relax along with it, it tends to work a little longer, although there are no studies to tell that. But usually they come back based on how much benefit they've had. So thank you. I hope that was a good enough overview just for the basic beginners.
Thank you, Dr. Radhija, for this amazing presentation as always. For the interest of time, we will move to the next speaker. So I am calling Dr. Indu to introduce the next speaker.
Good evening, everyone. Let me thank KSOS, Bastin sir, Marian ma'am, and Dr. Shaban for having me here. So without wasting time, let's move on to the next talk. It's a pleasure to introduce Dr. Neha Sri Rao. She did her DNB and fellowship in Oculoplasty and Orbit from Shankar Netralaya. Currently, she is working in various centers in Pune. She's a very passionate teacher and has been involved in various teaching programs. Today, she'll be talking to us about lid reconstruction. Over to Dr. Neha.
Good evening, everybody. It's been a pleasure to be a part of this webinar. I thank Dr. Marian and Dr. Shebin for involving me. I would be speaking on eyelid reconstruction. So I would be, the presentation is visible?
Yes, it's well visible.
Okay, so in this presentation, we will just be talking about what the goals are when we are looking to reconstruct the eyelid and some important points to remember, the basic guidelines, and just an overview of a few types of defects that we generally encounter in our clinical practice, and what are the practical considerations that we should keep in mind. So basically, the goals of any eyelid reconstruction is that we need to restore the anatomy that is reconstruct the anterior as well as the posterior lamella. So when we are reconstructing the posterior lamella, there has to be a mucosal surface that touches the cornea and not a keratinized surface. We need to restore an acceptable function of the eyelid, which is basically eyelid closure must be achieved, good eyelid closure. If the eyelid is mobile, that would be an additional advantage. Of course, last but not the least, we need to get back the facial symmetry, so which helps the patient to face the world and get on with his life. And there are some practical considerations like the age of the patient, the systemic conditions, your the shortcomings or the limitations that you have in your clinical practice, and which will help you give least surgical morbidity to the patient. So we need to remember that when we reconstruct the eyelid, we need to have a bilamellar reconstruction. That is, we reconstruct the anterior lamella and posterior lamella separately. So either it could be a flap for the anterior lamella and a graft for the posterior lamella, or vice versa, or we can have two flaps, but never we can have two grafts together for the anterior and posterior lamella. Whenever we are reconstructing the eyelid, there should be no vertical tension on the eyelid that will cause an ectropion or a lack of thalamus in the long run. So there has to be no tension on the wound. And whenever the canthus is involved, we must reform the canthus and fix the canthus. So basically, the lid defects would be of two types, either only the isolated anterior lamellar defects or the full thickness eyelid defects, which can be further broken down into less than 1/3, 1/3 to half, and more than half of the total eyelid. Just a small mention of the facial units before we go on to the reconstruction. These are the different facial units. This is just a picture I picked up from the textbook Leather Barrow that we usually refer to. So these are the various facial units that are there. And whenever we reconstruct, we should try as much as possible not to mix the two facial units. This helps in reducing the scarring. Of course, if there is no other way to do it, we can go ahead and borrow tissue from the other facial unit. But ideal reconstruction would involve the reconstruction to remain in the particular facial unit. So when we have isolated anterior lamellar defects, which are small, like say less than half, we can either go with the laissez-faire technique, that is just allow it to granulate, or a primary suturing, with undermining or advancement of the tissue. If it is a larger defect, we can go with flaps from the surrounding tissues, or a full thickness skin graft. Split thickness skin graft usually we don't use in the eyelids unless there is no full thickness skin graft available. For example, in cases of vitriolage or burns, sometimes there's no place that you can take a full thickness skin graft from. So in these cases, the split thickness skin graft would be considered. In cases of full thickness upper eyelid defects, now if the defect is less than half, we can either just get away with primary suturing or suturing with a canthotomy cantholysis. Now lateral canthotomy and cantholysis provides a little bit of laxity, not a little bit, actually quite a lot of laxity to the wound, and it helps you to primarily close the wound. For example, this patient who had almost a 1/3 defect over the upper lid has been closed just with direct suturing. This is just 1 week post-op, and you can see that the edges are everted, which is ideal because when the edges heal, they invert within a month or two's time, so which will give a good contour to the eyelid. Now, when you have defects which are a little larger, that is 1/3 to half of the lid, then Tenz's flap is my go-to procedure. It's a very simple and procedure which can be reproduced very easily. It is basically a semicircular advancement flap, and it's a musculocutaneous flap. So it can be used to reconstruct only the anterior lamella. You need to do something for the posterior lamella, which we will discuss further. So what usually we do is, for example, here there is a lower eyelid defect, and the semicircular flap is raised from the upper part. Ideally, this flap should remain within the orbital rims, and it should not go above the eyebrow. So there are a few rules that we need to follow. So, and we need to do a canthotomic cantholysis and then reform the lateral canthus by suturing the available orbicularis to the lateral orbital rim. So this lady who had a sebaceous gland carcinoma here, this is just 1 week post-op tensils, and this is 1 month post-op. As you can see, the aesthetically the outcome is quite good, and but we do need to remember that we need to reconstruct the posterior lamella. So how do we reconstruct the posterior lamella in these cases? If either we can dissect and advance the surrounding conjunctiva and suture it to the and advance it and suture it to the rim, or we can have a sliding tarsoconjunctival graft from the same lid. So sliding tarsoconjunctival graft, which was done for this lady also, we had a small incision given here, half of the length of the available tarsus, which was pulled, and we could thereby easily close this defect. There was no tension on the wound. So this is a sliding tarsoconjunctival graft, and or either a conjunctival transposition flap from the opposite lid. So in case the defect is a little large and there's not much available tarsus, or you do not want to compromise the available tarsus, we can just dissect from the lower lid and transpose the flap to the upper lid, the conjunctival flap. This transposition is more useful for the lower lid defects. Now, when you have a defect which is more than half of the entire length of the lid, we can either go for certain bridging or occlusive procedures like Cutler beard or Mastard's lid switch, or we can go for a non-bridging or non-occlusive procedures like anterior lamellar flap and posterior lamellar graft. Excuse me. So Cutler beard reconstruction, for example, these are the pictures. This gentleman had a huge tumor from the in the upper lid, which was excised, and this is the defect which is left over. So we had a conjunctival flap taken from the lower lid, which was sutured up here, and we had a skin graft for the upper lid. So the outcome, as you can see, is quite acceptable. Mastard's lid switch is the only procedure that gives you lashes in the reconstructed area. So basically, it transfers the upper lid defect to the lower lid, and the entire lower lid the full thickness lower lid is transposed to the upper lid. So basically, when you have a defect, for example, if this is the defect, the midpoint of the defect is marked, which forms the hinge of your lid switch, and either you can base the hinge. Either you can base the flap laterally or medially to the hinge, depending upon the available tissue. But you should remember that the upper lid defect, the size of the upper lid defect should be reduced to 25% of the total length. This is because 25% of the defect can be closed with direct suturing. So here is one of the pictures where the upper lid of the right eye was reconstructed with Mastard's lid switch. This is a lid coloboma case. So we had to separate
Dr. Neha.
Yeah, I'm sorry. Sorry for the inconvenience. Yeah. So yeah, so this is a child with coloboma, where the upper lid was. It's basically a aborted cryptophthalmos case. So even the posterior lamella was deficient. So we had done an amniotic membrane graft for the posterior lamella and raised this lower lid flap with the measurements of the Mustardage lid switch and sutured. So basically in this reconstruction, we need to respect the tissues. If we can find the levator and suture it to the flap, we can have a good lid function also in the post-op period. Usually this is how the flap looks after it is made, and it can be divided anywhere between 4 to 6 weeks. So full thickness lower eyelid defects, if they are less than 1/3, of course, they can be closed just with primary suturing or with lateral canthotomy cantholysis. And if they are 1/3 to half, then Tenzi's flap. This is one of the examples of a Tenzi's flap. Now, if they are more than half of the defects, we can use either a Hughes flap, in which we take the entire upper lid along with the skin and the conjunctival tissue, or a modified Hughes flap, where only the tarsoconjunctival flap is taken from the upper lid and a skin graft or a cheek flap is used for the anterior lamella. So in these, okay, I'll come to it next. We can also use a non-bridging or a non-occlusive technique, where we use a posterior lamella graft like mucous membrane graft for the posterior lamella and a skin flap for the anterior lamella. So this lady, for example, had a sebaceous gland carcinoma and a large defect along with the lateral canthus, which was sacrificed after the wide excision. So here we have taken a graft conjunctival flap from the upper lamella, upper lid. So what we have done is above the tarsus, I'm sorry, this is not a tarsoconjunctival flap, it is just a conjunctival flap. So what we have done is starting from the upper border of the tarsus, we have dissected the conjunctiva only, not the molars, only the conjunctiva, and undermined it and sutured the edge to the lower inferior phonacial edge here. So that will give you the posterior lamella. And then we have slightly undermined the tissue to reduce the vertical defect and put a full thickness skin graft from the post-auricular area. So this is how it looks in the post-op periods, and this is the outcome a month after her flap division, which can be done anywhere 4 to 6 weeks from the primary procedure. So what are the practical considerations that how do we choose what procedure has to be done for whom? So first is the age of the patient. Now, if it is a very young patient, like amblyogenic age group, you would not like to use a occlusive or a bridging, kind of reconstruction for the patient, because it would induce amblyopia. Secondly, how is the periocular skin, the facial skin, whether there is any laxity or not, whether you will be able to mobilize tissue from the surrounding areas, or will you be needing a skin graft if there is not much mobility and laxity? What is the general condition of the patient? If the patient is very fragile or not able to undergo general anesthesia, all these reconsideration we need to set up. One of the practical difficulties is the operative setup. If you're not operating in a multi-specialty hospital or somewhere where GA facility is not available, and you need to do the surgery under local anesthesia. Also, what is your preference? I may feel that a Tensys is works best in my hand. Someone else may feel that, no, I would prefer to do a skin graft. It gives me better results. So all these things are just the practical reconsiderations that, as you go on doing the cases, you realize them. So the take-home message would be that whatever reconstruction we do, we have to remember that we have to reconstruct both the posterior and anterior lamella and give a good eyelid closure. Those are our primary goals of the procedure. Then next would be that we need to take a case-to-case decision what we have to do for the for every patient, and we need to choose a procedure with causing the least discomfort and the least surgical morbidity to the patient. Thank you. I hope I could do justice to the talk in the limited time.
I know this is a very vast topic.
Yes.
Thank you, Dr. Neha. Yeah.
Thank you for the opportunity.
Yeah. Okay. Now I invite Dr. Nandini. Yeah. Hi. Dr. Indu is introducing Dr. Nandini now.
Yes, hello.
Yeah.
Yes.
Doctor,
Yeah. I'm happy to introduce Dr. Nandini Bodhra. She is a consultant in the Department of Dacryology and Oculoplasty in LVPI, in the prestigious LVPI in Hyderabad. She completed her Oculoplasty and Orbit Fellowship from LVPI Hyderabad and did her Sino-Orbital and Rhinology Fellowship from Massachusetts Eye Institute and from Harvard Medical School. She has many publications and has won many awards at national and international levels. Dr. Nandini will enlighten us with what's new in chronic canaliculitis. Over to you, Dr. Nandini.
Thank you so much, Dr. Indu. Am I audible?
You're audible.
Yes, very.
Right. So I'll just share my slides. At the outset, I want to thank Dr. Marian and her team for giving me this opportunity. Thank you so much for making me a part of this webinar.
It's a pleasure.
Is it visible and is full screen?
Yeah.
yes, ma'am.
Right.
Yes.
So now chronic canaliculitis per se is a very difficult topic. So I've sort of merged both the presentations and called it infectious canaliculitis. So as we know, canaliculitis forms about 0.8 to 2% of all the lacrimal disorders and has a female preponderance. This is what we know from literature. But what we don't know is that most of these cases are often are often diagnosed very late or are misdiagnosed because the presentation is often not very clear. So let us just look at few presentations. How do they present? So if you look at the first picture on the top left column, you see a nice swelling in the medial part of the upper eyelid, and you see associated discharge with it. Now, when you see a picture like this, it becomes pretty clear that we are sort of most likely dealing with canaliculitis. At this stage, you would like to evert the eyelid and look at the punctal and the canalicular area. Now look at the second picture. So all of these are completely unrelated pictures. I'm just trying to show different presentations of canaliculitis. So look at the second picture. When you evert the eyelid, you see chronic congestion of the conjunctiva. Along with that, when you look at the punctal margin or at the punctal rim, you see there is a lot of discharge there. And this is what we call a typical pouting punctum, which is the known sign for acute canaliculitis. So when you see a picture like this, we can more often than not, we do not really misdiagnose this. We do not really miss this. So this is the typical picture of acute canaliculitis. Now let us look at the row, at the bottom row. Look at the first picture. So this was this 30-year-old gentleman who presented to us with complaints of epiphora from his left eye. Now, what do you see in the left eye? Apart from very minimal congestion in the caruncular area, you really cannot make out anything. But there is a complaint of chronic epiphora for the past 6 to 8 months. So in cases like this, we should definitely evert the puncta and have a look at what we can find on the inside. Now look at the second picture. Now this on the upper eyelid, you can see that the punctal rim is swollen and the mucosa around it is swollen. It doesn't look normal, right? Now here, when you actually press onto the canalicular area, you can actually see discharge popping out. So this is a case of chronic canaliculitis. When it has been there for a very long time, it does not have acute symptoms like we see on the top row, but has very subtle symptoms. And it is very important to identify these subtle presentations. Similarly, let us look at the third picture on the bottom row. You can see that there is no classical punctum pouting here, but you can see that there is congestion on the medial part of the eyelid, that is in the pars lacrimalis area of the eyelid, and you also see some sort of yellowish discharge which is accumulated in this area. Again, just take 2 earbuds. I mean, it's not very difficult. Put some paraffin, take 2 earbuds and just squeeze the canalicular area, and you will see those typical sulfur granules or concretions, as we call it, popping out of this puncta. So don't always look for punctal pouting or active discharge. A very comprehensive history and very comprehensive slit lamp examination will often help us pick up chronic cases. So, like, for example, this lady presented to us, she was like a 25-year-old lady who presented to us with chronic epiphora. Now, she says that the epiphora has been there for like 6 to 8 months. And if you actually look at her eye, you can see the palpebral fissure height is sort of diminished, and you see an elevated tear meniscus height right here. So there is definitely something that is happening in this eye. The other very subtle sign is you see that the medial part of the lower eyelid is pushed up slightly. And then when you evert, you don't see a pouting punctum, but again, you see a fullness in the canalicular area. If you have seen about 100 eyelids normally, you would actually appreciate this fullness in the pars lacrimalis area. And then when you press with a earbud, you will see classic concretions coming out of the puncta. So this is a classic case of chronic canaliculitis. Now let us move on to how do you treat it. So mostly how it was being treated was you do either a 1 snip or a 2 snip or a 3 snip at the puncta and at the vertical canaliculus, and then curate out all the contents or squeeze out all the contents. This was the most common procedure and is still being practiced most commonly out there. But should we be doing or distorting the anatomy of the puncta is the question. So look at this picture over here. So this is the Horner Duernes muscle, which actually runs your lacrimal pump. Now this muscle is actually inserted all the way up till the punctal rim. So when you go ahead and do a snip, be it a 1 snip or a 2 snip or a 3 snip procedure, you are actually causing damage to the lacrimal pump. And when you do that, there may be chances that there will be persisting epiphora post resolution of the canaliculitis. So can we deal with canaliculitis without causing any anatomical distortion? So yes, we can. How do we do that? So we take a rapid taper punctal dilator or a short taper punctal dilator. So punctal dilators, if you actually look at the tip, they either are very short taper, that means they're very broad, or they are rapid taper, which means they're very thin. So you initially start with a rapid taper punctal dilator, slowly dilate it, and then use a short taper punctal dilator and make that opening large enough. How large do you want to make it? You want to make it large enough so that you can push in a number 1 curate. I'll show you what a number 1 curate is. So after you've dilated the puncta nicely, use 2 cotton buds and gently press in the canalicular area and drain out whatever contents you can. Now this is your typical Calazion curate. It's nothing new. It's not an instrument that you would not have in your clinic. Any oculoplasty or any ophthalmology setup would have a Calazion curate. Now this is a number 1 curate. So you acquire that and slowly and very gently get into the vertical canaliculus, make this curate parallel to the lid margin and gently sweep along the canaliculus and drain out all the possible contents into the canaliculus. And once you've drained this content out, you directly place it onto a chocolate agar or a blood agar and send it for culture so that you know which organism is causing it. Now, as we know, the most common organism is that has been isolated is Staph aureus. However, it is actually it is not actually Staph aureus. Staph aureus is a very spurious growth that we get on culture because we do not use anaerobic medias. So that is why a lot of times we just go ahead with a mixed kind of topical treatment. So in most of the cases, chloramphenicol really works very well. So just start the patient after doing the entire curettage, start the patient on chloramphenicol eye drops 4 times a day for at least 2 weeks, and then review the patient. Review whether signs and symptoms have resolved. If they have resolved, at least in my practice, I continue this chloramphenicol eye drops for another 2 weeks. So that is a total of 1 month, because that really helps to keep the infection under control, because these cases are known to recur. So this is just a dacryendoscopy picture that we had taken after we did the curettage, to show that if you do a very gentle curettage, there is no damage to the canalicular mucosa. So make sure that you use a 1-number curette, and second, you do it very gently. Do not scrape along the walls of the canaliculus. Just do it very gently so that you do not damage the canalicular mucosa, because if you do that, it can cause fibrosis and hence canalicular obstruction. So I'm just going to show you 1 or 2 pictures of a case that deviates from what is normal. Okay, so this is a case of acute canaliculitis. Again, look at picture A and B. There is absolutely no doubt that this is a case of acute canaliculitis. But as we were curating, we could see that there was a fistula which had formed in the mid segment of the canaliculus. So canaliculitis with a canalicular fistula is a very, very rare presentations, with about just 2 to 3 cases that have been reported in literature. Now, why I have put this, when you see a picture like this, do not intubate. You know, whenever we see that there is a breach, we treat it like trauma and we intubate or put a monocanalicular stent. But here we're dealing with an acute infection. So we will not intubate. Just remove all the possible concretions from inside, start medical management, leave it as such. If at all the fistula persists even after healing, that is when we would go ahead and stent it and then suture it. But up until then, we will not do anything to the fistula. Now, another very it's not a very typical case, but it conforms to the topic that I was given, that's chronic canaliculitis. So this was a lady who presented to us from Middle East, who had this swelling in the lower eyelid for the past 3 to 4 years. Now she's undergone treatment in Middle East. We do not have the details of that, but then she presented to one, and one of our fellows actually went ahead. They did curettage and started her on treatment. Now I see this lady after 2 weeks, and this is the presentation that I see after 2 weeks of curettage. Now what was missed? Can you see that swelling in this area of the medial part of the lower eyelid? Now when you evert, look at the swelling that is there on the inside as well. So there is something sitting in the ampullary area, which is like really big. So we went ahead and we performed another curettage. Now, these are very few cases where you would go ahead and do a snip. So when would you snip is one of the indications is this. So because when we opened up the puncta, we saw a giant canaliculolith sitting in the ampullary area. So we went ahead, we did a 1 snip punctoplasty. After doing that, using the blunt forceps and the Vanna scissors, we went ahead and pushed that canaliculolith out of the vertical canaliculus and the punctal rim, and just look at the size of the canaliculolith that was just sitting within the canaliculus. Now, when you have a chronic case which has been like that for years together, the concretions inside can actually form a mass and can form a canaliculolith and just sit inside without resolution. And these produce continuous discharge and epiphora, which is the complaint the patient presented to us with. So this is how her puncta and the canaliculus was after we removed the canaliculolith, and we can see no residual discharge. Again, she was started on chloramphenicol eye drops, and she did very well at the end of 1 month. So thank you.
Thank you so much for giving a different dimension to canaliculitis per se. Like very interesting cases and discussion. Thank you so much.
Thank you, Dr. Marian.
Thank you, Dr. Nandini. Next, it gives me pleasure to introduce the next speaker, who was also my teacher, Dr. Kirti Koka. She did her long-term clinical fellowship in orbit and oculoplasty at Shankar Nethralaya, Chennai. She went on to do observership under Dr. B.C.K. Patel at Moran Eye Center, Utah, and Dr. Beta Ismaili at the MD Anderson Cancer Center, Houston. Her areas of interest are orbit and adnexal oncology, eyelid surgeries, and thyroid eye disease. She has numerous peer articles in peer-reviewed journals to her credit, and she has numerous presentations at national and international conferences. I warmly welcome you to today's talk.
Thank you so much, Anju, for the kind introduction. I'd like to thank Dr. Marian, Dr. Shebin, and Dr. Annie for giving me this opportunity to be part of this webinar. I'm just sharing my slides. Is it visible?
Yes.
Yes.
Okay. So this is something we see in our daily practice every day. Patients walking in with drooping, right? But sometimes when we just do a simple test like a cover test, we realize that the patient clearly doesn't have a drooping. So there is something else. So all that meets the eye is not what it is. So it's important for us to know that every case that sees us is not just a pure, simple ptosis. As we know, ptosis is drooping of the upper eyelid. It can be a congenital or aponeurotic, which are the most common kinds that we have. But are all of them the same? So let's see a series of cases. So this middle-aged lady presented to us with drooping of her upper lid. You can see she has an MRD of -1. And when we examined her extraocular movements, we noticed that her elevation was restricted and she also had a mild exotropia. So what were we thinking of? Drooping with restriction of movement. We're thinking of a monocular elevation deficit or a partial third nerve palsy because it was present since birth. We're thinking of something congenital. However, on palpation, we felt that she had some kind of mass in the superior orbit. She had some kind of fullness. So we went on to do a Hertels and you notice that she has a 3 mm of proptosis in the right eye. So normal congenital ptosis MED should not have this 3 mm. So we went ahead and did an imaging. And what do we see? We see a hypodense lesion sitting in the superior orbit above the SRLPS complex. So then the patient was posted for a superior anterior orbitotomy for removal of this mass, which came out to have pilosebaceous units and it was diagnosed to be a dermoid. This patient post, you can see her elevation has improved and this is her later after a ptosis correction and she's doing well. So it's very important in any atypical case when you think there is something against the rule to do other examinations other than the routine ptosis evaluation, which includes a good Hertels exophthalmometry and palpation. So any patient is very important to palpate to rule out any other etiology. Here we have another patient, a 23-year-old male. He presented to us with sudden onset drooping for 13 days. And here you can see that his MRD, if you look at it, he has almost complete ptosis. And on extraocular movements, you can see his elevation restriction and he also has a mild proptosis. And the clinching thing here is a sudden onset ptosis in a 23-year-old. So always you have to keep your angina up. Here, we went ahead and did a diplopia charting because he was complaining of diplopia on elevating his lid. So you can see as a vertical diplopia. And one more interesting thing was we noticed in fields that he had an inferior field defect in that eye. So we went ahead and did an imaging. And to our surprise, we found that he had a well-defined lesion sitting at the orbital apex, compressing the SRLPS. And this had a small little hyperintensity inside. And this was like a scolex. So the diagnosis of cysticercosis was made. Patient was started on oral albendazole and tapering dose of oral steroids. And this is him post-treatment. And you can see his fields have also improved. So rather than rushing in and doing a ptosis surgery, sometimes imaging is very important in such cases, especially in patients who have a mild proptosis on Hertels, when you can feel a palpable mass. Or if you have a sudden onset ptosis in an adult, it's always better to image them before jumping in for a surgery. And if there's any features suggestive of inflammation. So talking about inflammation, this is another case. You can see this patient is a 35-year-old male. He is complaining of drooping of his left upper lid for the last 2 years. He complained of some amount of swelling which would keep coming on and off on the left upper lid. But at examination, he didn't have any particular swelling. But along with the ptosis, he had a little bit of thickening of his upper lid skin. So we went ahead and imaged, and here we found that he had a diffuse thickening, which was preseptal, involving his lids. And looking at the way the lesion was looking on imaging, we suspected a lymphoproliferative etiology. So we went ahead and did a biopsy from the lesion, and what we found was it was a necrotizing granulomatous inflammation. So since it was necrotizing, we went ahead and did a full workup. His staining for and granulomatous in India, we first thing want to think of TB. So TB was all negative. So then we did our entire vasculitis workup, and what did we find? We found that his C ANCA was positive. So that gives a diagnosis of granulomatosis with polyangiitis. He was then referred to a rheumatologist and started on steroids and immunosuppressants, and he started improving within 1 month of treatment. So in certain cases where even imaging is not confirmatory, it's important to biopsy and send for histopathology, because it is histopathology which gives us the diagnosis. So this is a child who presented to our clinic with drooping. He said that the drooping was present only for 2 to 3 years and it was variable. So he never gave a typical diurnal history, but he said he had a variable drooping. So the first thing we obviously think about is in such cases, myasthenia or some kind of ptosis that way. So we did a simple test, which is the eyes test. So we don't need to sometimes do elaborate blood tests and everything. Just a simple eyes test in the clinic is important, and that helps to clinch the diagnosis. It's a very simple test, which was where ice is placed on the upper lid. It is a highly sensitive and specific test for myasthenia gravis. The patient was then referred to neurologist and started on treatment. Now, this is a patient who's presenting with drooping. She says that the drooping is present only for 1 year. When we take her past history, there was no significant history as such that the patient could recollect, which was responsible for her drooping. So it's very important in such cases, especially in adults, to do a thorough slit lamp examination and evert the eyelids and check. So here, when we everted the lids, what do you see? You see that she's got membranes, she's got papillae. So this was basically a sequelae to an acute cicatrizing conjunctivitis and allergic conjunctivitis that has caused all these symptoms. So in such cases, especially if they're in the active phase, it's important to treat them symptomatically and only operate once the active phase has become inactive, because trying to operate them in the active phase will not give you accurate measurements also. This is another such patient who presented to our clinic. You can notice that her main complaint was the drooping. But if you look at her carefully, you'll notice that her upper lids are very thickened. They're not like the typical appearance that the normal upper lids have. So on everting her lids, and even here you can see there is some kind of irregularity on her surface. So on everting, you notice this yellowish plaque-like lesions all over her upper lid, involving the entire tarsal conjunctiva. So what do we do next? So we went ahead and biopsied her. And what did we find? She has all the typical features on histopathology and amyloid stain, which confirms the diagnosis of, Congo stain, which confirms the diagnosis of amyloidosis. So in such patients, it's important for us as clinicians, because sometimes they present only with eye symptoms first. So it's important for us to make a diagnosis and then refer them to the cardiologist, get electrophoresis, everything done, because they can have systemic involvement also. Now, this young male patient presented to us with drooping of the upper lid, and you can see he has a typical circumcorneal congestion. So not all drooping is always related to something involving the adnexa. There can also be an intraocular component which is responsible for drooping, and in this case, it was an iridocyclitis. Treating them with just steroids, homide, helps to improve and the patient recovers. So it's always important to look and do a thorough slit lamp examination in patients with such atypical presentations. Now, look at this lady. Her main complaint was she was complaining of drooping of her right upper lid. And she says that according to the patient, she has only noticed this drooping in the recent past. But it's always important to take out pictures from the past and look, because we noticed that more than the drooping, she was having an asymmetry in the tarsal show. So we asked her for all her old photos, and what do you notice? You notice that she has a mild brow ptosis in all her pre-existing photos with this asymmetrical show, which is probably worsened now because it has increased with age. Okay, so this is very important to do a thorough examination of clinical pictures. We call it it's called the family album tomography, because sometimes patients are not aware of it, so we can counsel them accordingly. And the type of surgery changes, because what she needed was a brow lift more than an actual ptosis correction. And in such a patient, if we had gone in and done a ptosis correction, she would not have been happy in the post-operative period. Simple other cases are like this child who actually has a hypertropia which gets corrected. So here this child needs to be referred to a squint clinic. It's not a true ptosis, it's a pseudotosis. So you need to refer them to the squint clinic for correction before we try to do a ptosis surgery. This is another example. Other things which could be other eyelid retraction. Patients generally are not aware of a lid retraction. They always look at the eye which is smaller as the pathological eye. This is actually a case of early thyroid hyperthyroidism which was setting in, which was causing the upper lid retraction. And this is a patient with a thysical, with a small microphthalmic eye, which is responsible for the drooping, though patient was very cosmetically concerned only about the drooping and not about the thysical eye. So ultrasound confirms in such patients, just a prosthetic shell helps to improve the appearance rather than doing a ptosis surgery. Thus, to conclude, ptosis is not it's a common condition, but what we as clinicians need to remember that it is not a diagnosis that we need to go ahead and operate. It is just a sign or symptom which requires thorough investigations to find out what the exact cause is for the ptosis. So any atypical ptosis, just the regular ptosis evaluation of MRD, LPS, Bell's, EOM is not enough. We need to sometimes go look ahead, do imaging, do biopsy sometimes to confirm the diagnosis. And doing this sometimes avoids needless ptosis surgery, which is going to cause a lot of trauma both to the patient and to us clinicians. Thank you.
Thank you so much, Dr. Kirti. Fantastic, fabulous collection of cases.
Thank you so much.
To be like very careful when you sit in OPD. Don't advise surgery. Yeah.
Exactly. Yes.
So today's last topic is on orbital foreign body by Dr. Shebin Salim, who is a consultant oculoplastic surgeon at Giridhar Eye Hospital, who has completed her long-term fellowship in oculoplasty from Shankara Nethralaya. Over to you, Dr. Shebin.
Thank you, Soumya. Hope my slides are visible. Okay, so Dr. Reena has already described most about the retained organic foreign bodies and their management. So I will briefly go through the remaining. So when it comes to a retained intra-orbital foreign body, some cases are very straightforward with clear-cut history, diagnosis, and a management plan. But some other cases can be really challenging with vague history, unusual presentations. So intraorbital foreign bodies, they usually follows high-velocity injury, or it can also occur following trivial trauma. Around 16% cases of orbital trauma could be associated with a foreign body. A high index of clinical suspicion and appropriate imaging are important in diagnosis and for a proper management. So they can be classified into metallic and non-metallic. And in non-metallic, they can be either inorganic or organic, or it could be combined, that is a combined substance like that of a pencil. And when it comes to wooden foreign body, this could be either natural wood or treated wood. Why I'm saying is this, because this can alter the imaging findings. So the clinical presentations can vary, including discharging sinus, proptosis, impaired motility, double vision, or features of orbital cellulitis, abscess, disturbances with the vision, or sometimes features of a superophthalmic fissure syndrome. So basically, the diagnosis depends upon two factors, that is taking a thorough and proper history and on the imaging. Always a high index of suspicion is important, especially in cases of trauma. Being said that, even in cases where patients are presenting with orbital infections or inflammations, we should ask for a history of trauma, especially in children and patients under the influence of substances. So CT is the preferred imaging modality. But when it comes to wooden foreign bodies, CT is often inconclusive due to variable radio density signal because of the variation in the water content or the hydration. So in CT, the dry wood appears hypodense, but fresh wood could be isodense to hyperdense depending upon the water content. So when it comes to a wooden intraorbital foreign body with a definitive history, or after ruling out with a CT of the presence of a metallic foreign body, MRI is the definitive imaging of choice. So this was a combined that I already mentioned, that as a pencil. Here we can see the typical appearance of this pencil. This is in the inferior orbit. So what are the indications for orbital foreign body removal? This can be remembered by the mnemonics called. This is described by Dr. Bipasha Mukherjee, my mentor. So one is S, which stands for size or sharp. Large sized and sharp foreign bodies should be removed, and contaminated or toxic, that is causing cellulitis, abscess, or fistula formation. So here comes one of the three metallic foreign bodies, that is copper, lead shot, or iron. So copper should be removed in all cases because it can cause severe or intense inflammatory reaction in the orbit. And though lead can cause systemic toxicity, in orbital cases it is not much reported. And in case of iron, if it is large and near to the sclera, it can definitely cause cirrhosis. So that should be removed. But if it is a very small iron foreign body, and if it is in a very difficult position to remove, then we can consider serial ERG to monitor for any photoreceptor toxicity. All organic foreign bodies should be removed. And if the location is anterior, and if it again, that it is better to remove it. If any foreign body causing any dysfunction, that is impinging on vital structures or causing a movement restriction, should be removed. Again, intracranial or sinus extension is a call for removal. So Dr. Fulcher et al. Has described nicely how to go about the management of a retained intraorbital foreign bodies. So first of all, we have to assess the injuries, including the ocular, orbital, or any systemic injuries. Then already mentioned appropriate imaging modalities, and anti-tetanus prophylaxis should be given in all cases. And in case of if it is a suspected organic foreign body, appropriate anaerobic coverage should also be given. So sorry. Yeah. So if it is organic foreign body, a surgical removal is indicated. When it is inorganic, if it is causing any orbital complications, again go for removal. And if it is anteriorly located without any orbital complications, we can discuss with the patient regarding the options of removal. And if it is a posteriorly located foreign body without any orbital or systemic complications, surgical removal is not indicated. So a few more points about the organic foreign body. So it's commonly seen in young males with vague history. There can be only in some cases, there will be only minimal signs or no signs of external trauma. So this is often missed or misdiagnosed in up to 33%. So a high index of suspicion is very, very important. So what is the problem with these organic foreign bodies? Because they have a porous structure, they act as a nidus for microbial growth, and they have this biofilm which decreases the efficiency of antibiotics. And also because of splintered foreign body, there is complete removal is always very difficult. So we can approach the foreign body by either of these routes: transconjunctival, transcutaneous, endoscopic, or sometimes combined approach. So most importantly, always evaluate for any globe rupture, and always weigh the risk of attempted removal versus risk of leaving the foreign body. And also, while removing, minimize the additional trauma. Meticulous removal of all fragments are very important. Careful debridement of the necrotic tissues and irrigation of the surgical wound with antibiotic solutions. Endoscopic assistance should be sought in selected cases. So few of the late complications include orbital granuloma, cellulitis, abscess, discharging sinus, even osteomyelitis, and non-infectious inflammation and fibrosis. So to conclude, a high index of suspicion is always important. Preoperative imaging in any cause of any patient with a trauma is important. The imaging features could be variable, so don't depend on that completely. Careful intraoperative exploration is important. There is always more than that meets the eye. Thank you. So with that, we came to the end of the session. So would like to know the expert and panelist opinion. Any questions regarding any topics?
Regarding the orbital foreign body, I think when your patient comes with history of fall, you should ask also into which object the patient has fallen onto. So I have missed the foreign body. He fell off on the bike. So then he came with an abscess, and I didn't ask where he fell onto. So he fell onto wooden foreign body. So it's just a dry stick, and always when you take out a wooden organic foreign body, tell them there is a possibility of some piece remaining there, and which may the patient presents with a discharge, he has to review again, and it has to be taken out again. Sometimes you can, even if you search for the small pieces, can remain there, wooden foreign body.
Okay, ma'am. Thank you so much. Yeah, definitely. Anything else? or else
Mm,
Mariam
Yeah.
ma'am?
Okay. What is the time that you have decided to? 9:30?
Actually, it was 9 o'clock, ma'am.
10 o'clock. Okay.
Okay.
So once in a
And
while, we can have some meetings like this. Yeah, I think we can
It's
continue.
okay. Nobody has slept. What do you do for chronic canaliculitis, Marian?
I do, that depends on like, if it is acute, like acute in the sense, the pus is like fluid, not much stones, like Dr. Nandini, I just cured the canaliculus and the punctum. If it is
Okay.
large stones which is not coming up, what I do is after cure it, I just do a syringing. If still stones are there, then I will snip. Otherwise, you will get recurrence.
Okay. I do a canaliculotomy. I don't disturb the
Ah,
punctum, but I do a canaliculotomy.
yeah.
So if you incise the canaliculus longitudinally, there is no canalicular block, but only if you cut the canaliculus transversely, there is a canalicular block, and we have to put the minimum. So you can easier to curate out the
For this
punctum
part.
than through the punctum.
That is called punctum sparing canaliculotomy, no?
I don't know. I don't know. I think
Dr. Nandini is there.
Freddie in the early days taught me to do that. Freddie from Ames.
Yeah,
I
yeah.
don't know nowadays what they do.
Nandini, you are like, yeah.
You're still there,
Yeah,
Nandini?
it is called a punctum sparing canaliculotomy. And
Okay.
it is a vertical, a horizontal incision, basically taken on the horizontal part of the canaliculus,
Yeah.
just for the ease of draining out all the concretions.
Mm.
Because
Okay.
until you drain out all the possible concretions, it is very difficult to cure that disease, and chances of recurrences are very high. And
Yeah.
that is why that was being practiced. Yes.
Yeah.
Do you
Not
do you inject any antibiotic ointment to prevent recurrence to the canaliculus?
I inject betadine solution at the end of the curettage. So just like how we do irrigation, similar, we take a irrigation cannula on a 1 cc syringe, and I inject betadine into the canaliculus.
Do you always give it for microbiological examination,
Yes.
or always you do?
Always. I mean, it's just for that odd chance where your antibiotic is not working, then it's very difficult to know what is the organism. So, and also since we're in an institute, I think it's a little easier
Yeah.
for us to sort of get microbiology culture.
Positive. Yeah.
Yeah.
I had done a case where the patient presented with a Roplas positive, and there was a canaliculitis, and the incongruences were extending to the sac.
Oh.
A very bad case. So
Yeah.
that also can occur, both can occur together. Rarely, only once I have encountered such a
Yeah, I've
case.
also seen it once so far where you have a where you have canaliculitis, like an acute presentation, but along with that, you have a NLD obstruction as well. So you will have those concretions extending into the lacrimal sac. Yes.
Okay. Then what was the talk before that? Before canaliculitis? Marie?
yeah, any
Lid
reconstruction?
reconstruction. Any doubts on that? Have you done this? Has anybody done Mustardi's transposition?
Let's see.
I've seen Dr. Nirmala do present a case. No?
Dr. Nirmala, she does routinely. I have not done. Now, studies lid switch, no?
Lid switch. And only, I think the advantage is you need not lose the lashes. Lashes can be retained. But till you separate the lids, it will be a little grotesque figure. Patient has to walk around with that. Yeah.
Regarding Dr. Reena's case presentation, there was a case of bilateral orbital cellulitis. In such cases, you have to look for cavernous sinus involvement if it is bilateral. Always look for the eye movements of the opposite eye. And there can be lateral rectus palsy, false localizing sign, if it is spreading to cavernous sinus.
Yes, but in this case, there was proptosis. I think fluctuating swellings on both lids. Should we think of any neuroblastoma or
Blood
chloroma and all that
investigations
in
are
bilateral?
negative, I think. Bone marrow and all were done negative.
Negative, yeah. She mentioned that. But we should think of that also and send
Yes.
for a biopsy and do bone marrow and all that if it's bilateral. But whenever there's pus, drain. Without draining, it won't resolve. This patient could easily have died within
Yeah.
yeah, so risky. Whenever there's pus, drain. Okay. Lid reconstruction. Then
Botox.
Botox. Botox. Yeah, Botox. Anne, do you have any? Indu and all are being quiet. Why everybody slept off or what? Indu, Saumya, they all left, I think.
Up to 6
No,
weeks,
ma'am,
they are
all have
saying
no,
it
we are
is
listening to
potent.
the
Why?
experts talk, ma'am. We are listening to the experts.
Oh, okay. No, you're all becoming experts. Yeah. Botox, what Anne was saying something?
She told we can keep it up to 6 weeks, right? We don't keep that long usually.
No, it is less effective. Even after 2 weeks I've tried, it's less effective. That's what I think. I don't know. What is your others' experience?
Hey, Dr. Ruthvi, what is your
Yeah. She's there now?
Yeah, actually, ma'am, what I found is with the Xeomin, which was available earlier, it
Okay.
actually did work even at 2
Oh,
months.
okay.
And there are even studies conducted on that. But you rightly said that the botulinum toxin does become a little less effective with time.
Okay. And it takes some 2 weeks to be effective. That also you should tell the patient, no? It takes
Right.
some time for it to become effective.
So the peak effect would be around that time.
Yeah, I read somewhere that if you untreated, if you apply cold application to that side of the face which is affected, it brings down the spasms a bit. I don't know. I'm just telling patients it doesn't cost anything, no, to fill gloves with little cold water and apply on the face 2 times a day. Those patients with blepharospasm. What is your experience with myectomy? Marian has done a few, I think, no? Myectomy.
Myectomy is good in selected cases.
After repeated Botox injections.
If you do properly, it will work.
Yeah. No, you do for apraxial lid opening or for hemifacial spasm, blepharospasm?
Blepharospasm, no, with apraxia. Blepharospasm,
Yeah, it is said to be effective with apraxia, but I did a case with recurrent. There was no Botox was not working, and the patient was very desperate. So I just did, and it is quite effective, I think. After the first post-op, this thing, I don't know if it will recur again.
No,
only the upper lid. I did only the upper lid myectomy, but it was effective on the first post-op visit. And no hematoma also, nothing. No ptosis, no hematoma. Maybe I did a limited myectomy only. Okay. Then what else is there to discuss?
Anything about ptosis?
Ptosis. Ptosis is ptosis. Anybody has done frontalis flap? You started doing, no? Frontalis flap.
Started.
Yeah. Indications. Akshay was saying that he does for Marcus guntosis, unilateral with no frontalis action, such cases. But how much muscle we have to undermine, how much till where we have to suture and all that, I don't know. Till it becomes a little immobile. The lid is becoming like lifeless. There is no dynamicity to the lid when you suture the frontalis flap. That's what I have found. Last vacations I have done, I think 4 or 5. We have to see the long-term results.
Yeah.
Okay.
I think
In orbital foreign body, Shebin, sometimes you can see an air bubble, air pocket. Sometimes that may be the only sign with an
Yes.
orbital wooden foreign body. I don't know how that air thing comes as the foreign body goes in, or is it an anaerobic infection which causes the air pocket around the foreign body? I don't know. Sometimes you see only an air pocket in the imaging in wood foreign bodies.
Yeah, but often the wooden can masquerade as a air pocket even when it comes in CTs.
Yeah. And if you follow the discharge, if you follow the pus, it will lead you to the
Foreign body. Okay,
foreign
fine.
body. So whenever the patient, tell the patient, if there is pus, come back quickly as possible.
okay, I think we will conclude.
Stop. Yeah. I already had dinner, so I'm not hungry.
Yeah, yet to have.
Okay.
Okay.
Thank you, Marian.
I know that Dr. Shem has to.
Thank you, ma'am. Thank you, ma'am. Thank you, all the expert panel moderators and all the speakers for being a part of this program instead of the last minute call. Thanks again. Thank you, Dr. Maria ma'am and Dr. Bastin sir for supporting for all the supports. So shall we conclude then? Bastin sir, please.
Dr. Bastin, he said he won't come. Yes.
Okay.
So thank you all once in a while. Welcome to KS, physical or presence to physical KSOS. Dr. Kirti, always welcome to KSOS. Thank you.
Thank you.
Thank you. Thank you so much.
Thank you